Great, thank you very much. I appreciate the opportunity to talk a little bit about what we do with our respiratory virus testing in pediatrics and some of the recent studies that we've been able to do on the whole logic Panther Fusion. So here are my disclosures for today, and talk just a little bit briefly about the epidemiology and types of infections caused by respiratory viruses. And then we'll look at some of the challenges of using more traditional methods for the diagnosis of these types of infections. And then I'll get into what we do in terms of algorithms for syndromic or seasonal respiratory virus testing and how in our laboratory molecular diagnostics plays a role. And then we'll finish up just a little bit about how this might fit into diagnostic stewardship for respiratory virus testing. So let's just look briefly at some of the more important respiratory virus infections. We've had an excellent talk from Dr. Stelrecht on influenza. And of course, these are responsible for winter epidemics every year of respiratory illness affecting all age groups. And it's estimated that anywhere from 5 to 20% of the population is infected with flu every year, which then, of course, can result in a significant number of hospitalizations for certain patients. It's estimated that there are more than 200,000 hospitalizations due to flu every year. And likewise, a significant number of deaths due to flu, which varies anywhere usually from 6,000 to 36,000 deaths per year, with most of those occurring in persons greater than 65 years of age. And so this adds a lot of medical costs. A few years ago, a study estimated that this was somewhere between $10 and $12 billion a year in medical costs just in the United States alone. And then, of course, we have certain patient populations that we know are at high risk for complications due to influenza infection. And this is really just the list that's on the CDC website, but I'm sure it impacts your laboratories. For us, it's the younger kids and the immune-compromised types of patients. But so children less than 2 years of age are at high risk for influenza complications, and then adults at the other extreme of age, greater than 65 years of age, are also at risk. And then anybody with chronic pulmonary, cardiovascular, renal, hepatic, and so forth disorders can have significant complications due to flu. Those that are immune suppressed as well, pregnant or postpartum women, persons less than 19 on long-term aspirin therapy, some native populations, and then also residents of nursing homes and other chronic care facilities. So these are really the target groups that we want to ensure receive the most accurate and reliable type of influenza testing that we can provide to make sure that they get managed properly. Let's look at RSV infections, which is a big respiratory virus in our institution. It's estimated to cause about 50% of all pneumonias in children less than 3 years of age. It results in a lot of outpatient visits in young kids, around 2 million every year. We do see a lot of children hospitalized with RSV infection. It's estimated there are more than 100,000 hospitalizations just in the United States every year, resulting in more than $300 million in healthcare costs every year. And unfortunately, we do see a number of kids that succumb to RSV infection. Also, more recently, we've come to recognize that RSV is a significant player in the older population as well, where we do see a lot of hospitalizations and mortality due to RSV in patients greater than 65 years of age. So it's really RSV a pathogen most closely associated with severe disease at those extremes of age. So in the infants and young children, we see severe cases of bronchiolitis, pneumonia, tracheobronchitis, and then in the older adults, it can also cause pneumonia, but also pretty severe exacerbations of chronic obstructive pulmonary disease and congestive heart failure. Parainfluenza virus infections are thought to be the second leading cause of viral pneumonia that can lead to hospitalization, again, mostly in young kids, 2 to 5 years of age. Parainfluenza virus infections result in more than 250,000 ER visits per year, more than 70,000 hospitalizations per year, and probably at least 600,000 or so cases of croup, again, resulting in more than $200 million in healthcare costs on an annual basis. Adenoviruses, there's of course different serotypes of adenovirus that are associated with different types of infection or respiratory infection. Many times these are milder infections, except in certain patient populations like those that are immune compromised, in which case the case fatality rates can be quite high, mostly due to adenoviral pneumonia. In kids, we do see adenovirus, but it's a less frequent cause of pneumonia in that age group. And then human metapneumovirus infections, most of these, that should be 85% or so, most of these occur in the January to April time period every year. Again, about 5 to 15% of either upper respiratory tract infection or lower respiratory tract infection in infants and young children are due to human metapneumovirus. And it's estimated that there are probably about 55 clinic and 13 ED visits per 1,000 children annually due to metapneumovirus infection. Adults, it's less common that we see influenza-like illness or bronchitis or pneumonia due to metapneumovirus. So it's primarily a pediatric pathogen. But of course, most every one of us has been infected, whether symptomatically or asymptomatically, with metapneumovirus, since seroepidemiology studies show that by 5 years of age, at least 90% of individuals have evidence of prior metapneumovirus infection. And then finally, rhinovirus, of which there are more than 100 different serotypes, mainly causing common colds. Probably about half of common colds are due to rhinoviruses, but they can also be significant in terms of causing exacerbations of asthma or cystic fibrosis, and can cause bronchiolitis and pneumonia in certain patient populations, particularly those that are immune suppressed. And then if we're using a very sensitive assay like Rt-Pcr, and we sample a lot of asymptomatic people, there will be a small percentage, up to 20% or so, that may actually harbor rhinoviruses but be asymptomatic. So when we look at all of these different types of respiratory viruses, on one end of the spectrum, as I said, in our immune-compromised patients, so for example, stem cell transplant or solid organ transplant recipients, it's really important that we make an accurate diagnosis because these are very vulnerable populations. You can see here that there's a fairly high incidence of all of these respiratory viruses, both in stem cell transplant and solid organ transplant recipients, with, in many cases, fairly high mortality attributed to these respiratory viruses. So it really behooves us to try to identify these as quickly as we can, but also with very high accuracy. On the other end of the spectrum, in otherwise healthy individuals, we know that they can have uncomplicated upper respiratory tract infections, and it's estimated that there are probably at least 25 million or so physician visits due to these uncomplicated URIs, most of which are viral, but a lot of these patients do end up getting antibiotics, up to about 65% in some studies, unnecessary antibiotics, I should add. So there's a lot of direct annual healthcare costs and indirect costs associated with these uncomplicated upper respiratory tract infections in otherwise healthy individuals, a significant proportion of which can be attributed to unnecessary antibiotic utilization. So it really does, it's important that we're able to diagnose these respiratory virus infections. Antimicrobial stewardship is important in one aspect, and then also for our most vulnerable patients, we want to accurately diagnose these infections. So there have been a number of different type of modalities that have been employed over the years to diagnose respiratory virus infections, anywhere from sometimes looking to see if clinical diagnosis might work. We've had rapid antigen tests around for a number of years, direct immunofluorescent microscopy and cell culture, and then more recently, nucleic acid detection. So I'll just touch briefly on some of these methods. For clinical diagnosis, we know that, especially in children, there are limitations from making an accurate diagnosis of influenza just looking at signs and symptoms. Some patients that have high fever might increase the probability that it's an influenza infection, but of course not all influenza-like illness can be attributed to influenza. And then when they look at other signs and symptoms, they're really not good independent predictors that patient truly has influenza. In adults, older adults, healthy patients greater than 65 years of age, or high-risk adults over age 21 with either confirmed influenza or RSV infection, if we look at their symptoms, there's often a lot of overlap between those that have proven RSV and those that have proven influenza. So a lot of those patients are going to have nasal congestion, cough, sputum production, and so forth. So we can't reliably say whether they have this or that particular respiratory infection because the symptoms do overlap. So that's why we need to do some sort of diagnostic test, of course. And so we've had things like EIA and EIA-like tests for a number of years. There have been iterations that have been made more recently on these types of antigen detection tests. But basically, these really just allow us to detect 3 different viruses, right? So influenza A, influenza B, and RSV. Unlike some of the other tests, we really can't assess the specimen quality to know that it's a truly cellular sample representative of the upper respiratory tract. And as Dr. Stelrecht mentioned, we also know oftentimes these are much less sensitive types of tests. Using immunofluorescence for direct testing, DFA testing, we can potentially detect more viruses. Now we can look at the parainfluenza viruses, adenovirus, metapneumovirus, in addition to flu and Rsv. And we can also assess specimen adequacy as well. But these methods are very labor-intensive and are often less sensitive than when compared to nucleic acid detection methods. And then finally, cell culture, where we can use a variety of different cell lines potentially to detect a broad range of viruses that might be present in respiratory secretions. But here, of course, the collection, the transport of these samples is critical because we need to maintain the viability of those viruses before we can get them onto the cells. And again, it can be very time-consuming and labor-intensive to utilize these types of methods. So for nucleic acid amplification testing for respiratory viruses, I could probably make a list that would take up about 3 slides for all of the FDA-cleared assays. There are a lot of FDA-cleared assays for at least single targets, if not broader panels of respiratory viruses. So we have assays that may be just specific for flu A and B or RSV. We have some mini panels where we can combine flu A and flu B and RSV and that sort of thing. And then we have our broader, highly multiplexed type of respiratory panels where we can potentially detect upwards of 16 or 17 different targets from one sample at the same time. And these all vary in terms of their turnaround time. Some of them need to be performed in batch mode. Some can be performed on demand. And the turnaround time now has, as you've probably seen from a number of the newer assays, has really dramatically decreased from about 15 minutes for some of these nucleic acid detection tests, upwards of anywhere around 7 or 8 hours, depending on the platform. And then, as of just a few years ago, the complexity for some of these tests has decreased as well. So we now have, since 2015, the first molecular infectious disease tests with waived CLIA complexity. Many of them are moderate, and then there are also still a number of higher complexity tests for respiratory viruses. So when we're trying to consider which of these methods to use, one of the things that we want to assess is the turnaround time, which for rapid antigen and now even for molecular tests can be as short as 10 or 15 minutes. DFA will take a longer period of time, and cell culture, depending on how it's performed, can take days or even a couple of weeks before making a final result. And then we also want to look not only at turnaround time, but also the performance in terms of sensitivity. We know that the rapid antigen testing are suboptimal for things like flu and RSV. DFA might be a little bit more sensitive depending on the virus that we're looking at. Cell culture previously was thought to be the gold standard for these respiratory viruses, but we now know that molecular diagnostics is typically at least 90% or so sensitive or more for these respiratory pathogens. So let me tell you now a little bit about how respiratory virus testing has evolved the last few years at Texas Children's Hospital. We are currently about a 650-bed tertiary care teaching hospital affiliated with the Baylor College of Medicine. We serve over 30,000 admissions annually, more than 25,000 surgeries annually, over 100,000 ER visits per year, and a lot of critical patients that get transported to our facility. And importantly, we have a fairly large immunocompromised patient population at Texas Children's Hospital. Every year we have anywhere from about 450 to 500 new oncology patients, so ALL patients, some AML patients, that type of thing. And we do a fair amount of stem cell transplants for some of these patients. Some years upwards of 120 or 125 or so, depending on the year. And then we also are one of the few pediatric institutions that performs all of these different solid organ transplants: heart, lung, liver, and kidney. Some more than others, but every year we're doing a number of solid organ transplants. So this is just to show you that we have a significant immunocompromised patient population. for which we think it's important to have very accurate and reliable respiratory virus testing, because it's very critical before they immune suppress someone or go to transplant. They don't want to do that if the patient has a respiratory virus infection. So several years ago, prior to 2014, this was the kind of modalities that we had in place at Texas Children's. So we did have antigen detection that was performed basically 24/7, but just for flu A and B and RSV and adenovirus. There's the rapid antigen test for adenovirus that's been approved for conjunctival specimens. We had validated it also for respiratory specimens. Also prior to 2014, we also did DFA testing for flu, RSV, adeno, parainfluenza viruses, and metapneumovirus. And those were essentially batched once a day. So the turnaround time was typically about 24 hours. And then we were also doing culture prior to 2014. And these were conventional tube cultures, if anybody remembers those days. Not many people do. Interestingly, I was looking at the CAP proficiency survey on virus isolation that just came back, I think last week, and there were about 35 labs that had subscribed to the virus isolation CAP proficiency testing, and that number has just gone down dramatically just in the last 5 or 6 years as everybody moves away from cell culture-based testing. And then we also, in addition to those 3 modalities, we also had molecular testing, and we were using the Prodessa assays. Each of them is a separate kit, basically. The ProFlu for AB and RSV, the ProAdeno was a separate assay, the ProPara, which is picks up Para 1, 2, and 3, the ProMetapneumo, and then we also had our own lab-developed Rhinovirus Rt-Pcr, which was really rhinovirus specific. It doesn't really cross-react with enteroviruses. And we were extracting respiratory samples on the Kaya Symphony. This is prior to 2014, and all the Prodessa assays we would then run on the 96-well plates on the ABI 7500 instrument, and the lab-developed Rhinovirus Rt-Pcr was done on the light cycler. And these, all the testing for respiratory viruses was batched once a day, at least 5 days a week, sometimes 6 days a week during the respiratory season. So we had some, at this time, prior to 2014, we had some algorithms in place as to how and when we would do certain types of testing. So I don't know how well you can read this here, but this is our what's called our winter respiratory panel. And so the winter respiratory panel started with just flu A, flu B, and RSV testing. And if it was positive for flu A, we would go ahead and do molecular subtyping. We had a homebrew lab-developed test for flu A subtyping. If it was positive for either flu B or RSV, then we would stop. We would be done. So during the winter, when we expect to see mostly flu and RSV, if one of those is positive, then we stop there. But if it was negative for either, or for any of those or for all of the targets, flu A, flu B, and RSV, then we would reflex to run metapneumovirus, parainfluenza virus, and adenovirus on that same eluate, basically. And then if any of those targets were positive, then we were done testing that sample. If they were negative as well, then we would reflex that sample to cell culture. So it would go to tube cell culture. And then we also had what we called here, if you can read it, the summer respiratory panel. So in the summer, in July, we don't expect to see flu. We might see 1 or 2 RSV, but no flu. So what we see more frequently during that time period are the parainfluenza viruses and adenoviruses. So we had a summer respiratory panel that if it was positive for either of those targets, we would stop. We would be done. But if it was negative for paraflu or adenovirus, then we would send it for cell culture. And then we had our lab-developed Rhinovirus Rt-Pcr, which was a standalone test that had to be ordered separately. And as I said, these were batched once a day, run 6 days per week. So that's prior to 2014. Then we needed to make some changes. We really needed to, particularly for flu and RSV, as some of these more rapid on-demand tests became available, we need to consider moving somehow to more rapid flu and RSV testing. And we chose those targets in particular because, as I said, these are the main players during the winter months. And I'll show you an example of what happened during the 2014 respiratory season for us. And then we also want to target things like influenza that do have treatments available, so we can appropriately use and prescribe antivirals or antibiotics in some cases if it's not viral related. We also need to think about in certain patient populations, the young kids, the immunocompromised patients, if they're negative for flu or RSV, we need to think about other respiratory viruses or investigating other etiologies of the respiratory infection. But if we can rule in flu or RSV fairly rapidly, it should decrease unnecessary additional testing. And in some cases, when we're really peaking with a lot of flu and RSV, it can help with cohorting and infection control types of things. So I mentioned the 2013 and 14 winter season. And what you can see here on the x-axis is the month of the year. And then on the y-axis are the number of positive tests. The green here is RSV, and the red is flu A. So you can see that during this particular respiratory season, we had influenza A and RSV peaking about the same time in December of 2013. And that month, we tested about 2,100 respiratory specimens by PCR. And if you can see the numbers here, about 400 of those were positive for flu A, and about 600 were positive for RSV. So 50%, almost 50% of our respiratory specimens in December of 2013 were positive for either flu or RSV. So we wanted to, as I said, come up with a more rapid solution for flu and RSV testing specifically. So the following year, after that 13-14 season, we implemented what we called the Flu and Rsv Admission Panel, or the FRAP, F-R-A-P, on the GeneXpert system. And here, basically, on this panel, we start with flu A, flu B, and RSV, and that's run on demand on the GeneXpert 24/7. If it's positive for any of those targets, then we stop. We're done. If it's negative for all three, A, B, and RSV, then we reflex to testing for parainfluenza viruses, metapneumo, and adenovirus, and regardless of the answers from that second round, whether they're positive or negative, we go ahead and stop. So no more reflexing to cell culture and that type of thing. And then we work closely with our emergency center leadership because they were the primary users of our rapid flu and RSV testing when it was antigen testing, for example. So we wanted to make sure if we're going to use molecular testing for our ER patients, it's more expensive, but we get more gain because of the increased sensitivity and accuracy overall. So we worked with them to come up with which patients really need to have the molecular flu and RSV testing. So if a patient comes into the emergency center and they suspect that this patient has influenza infection, the first question to ask is, do they meet any of those CDC criteria for patients who might be at increased risk for complications due to influenza? So are they less than 2? Are they immune compromised? Do they have sickle cell? That sort of thing. Or are they going to be admitted to the hospital? Because presumably if they're sick enough to be admitted with respiratory symptoms, they should get an accurate flu and Rsv test. So if they meet those criteria, yes, then they can have the rapid flu Rsv PCR. And at the same time, if they're going to be admitted, they'll go ahead and start the first course, the first dose of Tamiflu. And then within a couple of hours, they'll have the gene expert flu and Rsv result. If it's positive for flu, then they'll go ahead and finish that course of treatment for flu. If it's negative for flu, then they can discontinue the use of antivirals for that patient. Now, on the other hand, if those patients do not meet the criteria, if they're not going to be admitted, if they don't meet the CDC criteria for those at high risk for complications due to flu, then those patients really shouldn't have testing. They should be managed more on a symptomatic basis. So testing isn't warranted for those patients. So in that case, if they really do have influenza-like illness, if the symptom duration is less than 48 hours, then they would probably be good candidates for antivirals. If they've had symptoms for greater than 48 hours, then at that point there's probably no need to provide empiric treatment. So this has been in place now since 2014 with this rapid flu Rsv Admission Panel. And a couple years ago, we went back and did an audit for a couple of months on the ER to see actually how if they were utilizing the rapid flu Rsv PCR appropriately. So we looked at 2 months, March and April of 2016. Remember, that season, flu was kind of late for most of us. So that's actually when we saw most of our flu. And during that time period, there were 682 patients that had the rapid flu Rsv PCR. About 17% had a positive flu, about 5% had a positive RSV, and then 17% had another respiratory virus. Remember, if it's negative for flu A, B, and RSV, then we test for parainfluenza, metapneumo, and adenovirus. So of these 682 patients, 65% were admitted during this time period. So that's a little off, but that's a check mark. So if they're admitted, they can have the rapid flu Rsv PCR. About 30% of these patients were discharged from the emergency center, but they met the CDC criteria. So they were either less than 2 years of age, they were immune compromised, they had sickle cell, metabolic disorder, that sort of thing. So they met the criteria. So that's another check mark for that group. But then there was this about just less than 5% that were discharged from the emergency center, but they didn't meet any of those CDC criteria. So they had flu Rsv testing, but they probably really shouldn't have. But overall, we ended up with just over 95% compliance with this particular algorithm that was implemented in the emergency center. And when I shared this data with them, they were ecstatic because they often are happy if they can get 80% of their providers to follow their other algorithm. So 95% is actually pretty good at our center. The other thing that we've done for many, many years is to provide weekly and monthly snapshots of what's happening in our community of patients that we see in terms of viral testing. So we have this viral epidemiology snapshot that's available internally and externally as well, that shows how many specimens we're testing for respiratory viruses or enteroviruses or herpes or whatnot. It includes both culture and molecular results. So the clinicians really can get a sense of, for example, they use this data when they decide when RSV prophylaxis should be provided to infants and high-risk patients for Synagis administration. So wanted to share just a little bit of our respiratory virus data. This is the from July 2014 to June 2015. You can see here in the winter, again, as we've discussed, in the green here we see mostly RSV, in the blue we see influenza A. But in the inset here, looking at the months of, for example, May, June, July, August, and September, we don't see flu during that time period. We're seeing these other metapneumo, adenovirus, parainfluenza viruses during that time period. And so that's one of the reasons, as I mentioned, we have this summer respiratory panel, which targets those types of viruses that we were more likely to see during the summer. And then we also have the winter respiratory panel for the other virus, starting with flu and RSV, because we would expect to see those more commonly. So our current state right now for respiratory virus testing, as I've shared with you, we have this rapid flu Rsv PCR that we use. We've done away now for the last several years with antigen detection, so we don't do any more flu, RSV, or adenovirus antigen detection. We've also discontinued direct immunofluorescence testing for respiratory viruses and have moved now from conventional tube culture to RMix for respiratory viruses. And then we still do also offer the Prodessa assays beyond the rapid flu and RSV PCR and the Gene Expert. We have the winter respiratory panel, which has the similar type of reflex that I showed before, except now we don't reflex to cell culture. That's been discontinued. And then we also have the summer respiratory panel for parainfluenza and adenovirus. Again, this time similar, but we don't reflex it to culture. I should say that we've moved away from the Kaya Symphony for extraction of the Prodessa assays and gone to the MagnaPure 96, and we still run that on 96 well plates on the ABI instrument. And then if we combine all of these different assays, we can come up with what we call our RVP, even though they're mostly separate assays. If we combine them all, we get the flu A, B, RSV, adenovirus, parainfluenza virus, metapneumovirus, and rhinovirus. So we have kind of a piecemeal RVP that we call our RVP. But again, we're still batching this, all of these assays once a day, 6 days a week. So we wanted to come up with a better way, perhaps, to do some of this respiratory virus testing. We are currently Panther users. We perform the CT/NG on the Panther. We also perform Zika virus testing on the Panther using the Aptima assay. And so the Fusion was attractive to us because it can be actually added on to a Panther system, or you can purchase the whole system all in one piece, but it can be added to the existing Panther if you have one in your laboratory. And as Dr. Stelrecht mentioned, these are modular panels. So we have A, B, and RSV is one mini panel, adeno, metapneumo, rhino, another mini panel, and then parainfluenza 1 to 4 is another mini panel. And so you can run just one of these assays, two or all three if you need to, and even within each of these assays you can select or deselect targets. So if I wanted to run just RSV, I could select just RSV. So I really can get down to just running what is ordered. And then the way that these panels are configured, this flexibility does allow us to to do the seasonal type of testing that we've been doing for a number of years, but just more in batch mode. And we can also kind of reconfigure this based on the epidemiology of what's circulating in the community. And so it just takes one single extraction from the M4 tube to run multiple assays using the TMA and real-time TMA plus PCR. So it really allows us to do it in a much more automated fashion with onboard extraction. As I said, we had been doing the MagnaPure 96, pipetting all of that, taking that, making our master mixes, going to 96 well plates. So all of that now is automated and it's performed on board in addition to the PCR setup. And so it does have the random access capability. So we can slide samples in throughout the day if we need to. We don't have to batch them all in one run. And they also have reagents on board that are stable for up to 60 days on the instrument. And the results are fairly timely, particularly since we're trying to do a broad number of respiratory viruses here. So the first results come off about just under 2.5 hours, which is the whole extraction and amplification process. And then 5 results come off about every 5 minutes or so. And then on the Fusion, we could potentially get about 335 results in an 8-hour shift, but even more so if we combine it with the Aptima assays on the Panther. So I can be running Panther assays and Fusion assays at the same time. So we wanted to take a look at how well this panel, these modular panels performed compared to our current assays. So that's the Prodessa assays, the Gene Expert, our lab-developed Rhinovirus assay. So we gathered fairly prospectively 285 respiratory samples during January through March of this year. And we wanted to look at a variety of sample types. Because, as I said, with our large immune-compromised patient population, we get various other sample types that it's important for us to be able to assess, BALs and trach aspirates in particular. So those are not on label, but important for us to be able to validate. So let's take a look at, first of all, the Flu A and B and RSV. We've already heard some data on the flu assays. So the Fusion, Flu A and Flu B testing in all of the sample types that we looked at was 100% concordance with our current assays. The RSV was a little bit more sensitive. We did pick up one additional RSV on the Fusion. And I like this feature here because it gives us a CT value on the Fusion. We get to see exactly how that sample performed in that reaction. So we get the CT values. Okay, and then let's look at the parainfluenza viruses in these various sample types. So Para1 and Para2 agreed 100% with our current assays. Para3, there were a couple of Para3s missed by the Fusion. I think that did pick up an extra Para3 as well. Some of the CTs were in the mid-30s on those samples. And then finally, the Adenoviruses and human rhinovirus, we saw the Fusion was able to pick up, for many of these viruses in various sample types, additional viruses that we had not detected initially using our current assays. So overall, we found that the Flu A and B and RSV was 100% sensitivity, as was the Adenoviruses and Rhinovirus, and Para1 and Para2, and then we had a small number of Para3s, but the Fusion missed a few of those. And I mentioned earlier that the Fusion also detects Parainfluenza 4. We had not currently been testing for Parainfluenza 4, but we had some Para4s that were positive on the Fusion, and we were able to confirm those. I think we had about 6 or so that were Para4 in this sample set that we were using, and we were able to confirm those with another multiplex PCR assay. So with this type of capability, where I see our future state for respiratory virus testing going, I think we're going to keep our rapid flu and Rsv PCR that can be done 24/7 on demand, but now we want to have the broad respiratory panel capabilities, which we can with the Fusion by running all 3 mini panels at the same time. And then we also want to keep, I think, a summer respiratory panel where we don't expect to see flu and Rsv, but we do expect that we're going to see parainfluenza, adeno, and metapneumo, and probably some rhinovirus we might include in there as well. So we can adjust our testing with this flexibility on the Fusion to meet the season and what we would expect to see. And because of the random access capabilities available, we could potentially be putting samples on as they come in throughout the day and even into second shift. And so we get those results out in a more timely manner instead of waiting to run daily batches. So I think it's really important for us in the laboratory, of course, to choose the right test, and this involves us doing some in-depth evaluation, selecting and implementing the right test for our institution's needs, for our patient population, and then give some guidance. We need to help the clinicians judiciously use some of these molecular tests and make sure that they're testing the right patient at the right time and getting samples to us in a timely manner so that we can optimally influence clinical care and perhaps conserve healthcare resources in doing so. So in summary, we've talked about how common respiratory viruses are and how they significantly impact health and our economy, and how test methods for diagnosis should be based on their performance characteristics, the targets they include, and the need for the particular patient population that's being tested. And our data shows that the Fusion can allow for flexible random access and very sensitive respiratory virus detection so that we can personalize testing perhaps in a more cost-effective manner.